Mr. Chairman, ladies and gentlemen, it's a great pleasure to be here, to be able to present some data also on pediatric cancer in the perspective of predictive, preventive, personalized medicine, which is a fascinating one. Certainly will help not only millions, but I think billions of people. And in the perspective of PPPM, I think we can also reanalyze some of your models of carcinogenesis, some of the so-called dogmas, and maybe change the general medical perspective, which is typically a top-down approach. One of the most accepted models is certainly the one of progression of cancer, classical model exemplified by the model of Bogelstein and Johns Hopkins and by the famous paper, probably the most quoted paper in cancer research, Hahn and Weinberg itself. Essentially, progression parallels the accrual of new mutations and new derangements or aberrations, genetic aberrations. But certainly this is not the only model. And we know today that some models, particularly pediatric cancer, are totally different. Indeed, we know, for example, that the tumor I will talk about within neuroblastoma behaves totally differently. The patient, the children arrive at diagnosis already with a disease which, in terms of future outcome, will be already classified as very aggressive or essentially benign tumor. And we can see this from the famous approach of Desiderio a few years ago. This is probably one of the first examples of personalized medicine. The prognostic outcome of patients which do not have amplification of MYC is much better than the ones with disorder gene amplified. However, we still don't understand why this is happening. In a model proposed still by Desiderio, what we can hypothesize is that we have a target cell, most likely cancer stem cell, original stem cell, which behaves different to some carcinogenic insults. And so some cells might just alter their mitotic apparatus, becoming aneuploid or triploid, and they behave much better, much better prognosis, while cells which tend to scramble their genomes, making segmental chromosome aberrations like MYC amplifications or 1q deletions, they lead to aggressive cancer. So with this model in mind, we also should remember, and I go a little bit in the past myself as well, this year marks the 100th anniversary of the discovery of the first antigenic virus by Peyton Rouse, and obviously viruses do play a role in human cancer. This is particularly visible in pediatric cancers where certain cancer clusters or geographical association, space and time association of tumors have been described in the past. Here you see some examples from the UK. The famous class of Sellafield, for example, studied by Neil Killen, and others studied in US, Fallon, Nevada is one, Niles, Illinois is another famous one, studied by Charles Heath. They all point toward the presence of an infecting agent, and in fact, Neil Killen himself has hypothesized the presence of an X virus which will be carried on by healthy controls. And these models actually coincide with the ones proposed also by Melanie Reeves in the UK. Reeves has shown evidence for genetic derangement present already at birth, so it will be a prenatal event. However, this event has to be triggered eventually by an infecting agent as well. With this in mind, you will understand probably our model, which was based on the study of cancer clusters, space-time association of neuroblastoma cases, so a solid tumor, We studied this in Louisiana, and as you can see, these tumors have a dramatic presence of genomic alterations at the DNA level, which is NMIC amplified in this tumor approximately 1,000 times, so some kind of monstrosity at the genomic level. In these cultures, we also have evidence for genetic instability, and from that, we hypothesized the presence of an infecting agent. We discovered this virus, which we have called microfoci. These are the foci appearing on the tumor cells. Microfoci-inducing virus, a cytoplasmic virus, approximately 77, 79 nanometers.